In this video series, we will discuss cervical dysplasia and cervical cancer. While understanding dysplasia and cancer is of course going to be important in this discussion, we must first be able to understand the various modalities that we have at our disposal to evaluate cervical dysplasia and cervical cancer. These modalities include the pap smear, colposcopy, the endocervical curettage, abbreviated as ECC, the cone biopsy, which you may also see referred to as conization, the loop electrosurgical excision procedure, also known as LEEP, as well as cryotherapy. As a medical student, I felt as though these modalities were often discussed and these terms were thrown around. However, they were very rarely, if ever, clarified in terms of what they actually mean and what these modalities actually do for our patients. So first and foremost, I would just like to outline how each of these modalities work and how they fit into our evaluation and workup of cervical pathology. First up, we have the pap smear, which of course is a screening test for cervical dysplasia. The pap smear is going to sample the transformation zone, which is located at the squamocolumnar junction between the cervix and the vagina. This can be appreciated on the right-hand side of the presentation, where you can see that we have this classic pap smear brush, and it is sampling from the transformation zone located here at this junction between the cervix and the vagina, known as the squamocolumnar junction. Once a female patient reaches age 21, she should have a pap smear performed every 3 years, or alternatively, that patient can have a pap smear with HPV testing performed every 5 years. Ultimately, the timing of when to perform pap smears gets more complicated once we discuss the results from various pap smears in terms of what they mean in terms of the possibility of cervical dysplasia. But for our purposes here, knowing that at age 21, a patient should get a pap smear every 3 years or a pap smear plus HPV testing every 5 years will be sufficient for our purposes here for now. Next up, we have colposcopy, which can be used to further evaluate any pap smear that is deemed to be abnormal. There are typically 5 steps that are involved during colposcopy. First, we insert a speculum, and next we apply acetic acid to the region, particularly the transformation zone between the cervix and vagina. We then insert a colposcope, which is really just a fancy microscope, to evaluate the transformation zone. We then have 2 options of what we can do next. We can perform small biopsies. We then have 2 options of what we can do next. We can perform small biopsies of suspicious areas that may appear concerning for cervical dysplasia, or we can perform an endocervical curettage, or ECC. We will discuss ECC in more detail in the following slides. However, for our purposes here, I would just like to note that performing small biopsies during a colposcopy is considered to be safe during pregnancy. However, performing an ECC is generally considered to be contraindicated in pregnancy, as it carries, among other risks, an increased risk for the development of preterm labor. As we mentioned on the previous slide, during colposcopy, we can choose to perform endocervical curettage, or ECC. During an endocervical curettage, we use a curette or knife in order to scrape the endocervix for cytology and to ultimately look at these cells under the microscope. On the right-hand side of the presentation, we can appreciate the use of this curette here, which is essentially sampling the endocervix in order to look at these cells under the microscope. If during the ECC we scrape these cells and we are able to see cervical intraepithelial neoplasia 2, or CIN3, then we can proceed with either a cone biopsy or conization, or we can perform a LEEP procedure, and we will discuss what these procedures entail in the coming slides. However, it is worth re-emphasizing that when we perform an ECC, we increase the risk of preterm labor and cervical stenosis, and this really should not be surprising, as if we are applying this curette and scraping cells from the endocervix, then this can ultimately result in alteration of the cervical anatomy and ultimately preterm labor and stenosis of that cervical canal. And we discuss this in more detail in our modules on preterm labor. So just to reiterate, if our ECC shows CIN2 or CIN3, then we can move on to either a cone biopsy or a LEEP procedure. In the case of a cone biopsy or conization, we're going to remove a cone-shaped piece of the cervix. This can be appreciated in the schematic on the right-hand side of the presentation, where we can see this cone-shaped piece of cervix that we are ultimately removing with the use of this curette. It is important to keep in mind that in contrast to some of our other procedures, such as a pap smear or colposcopy, or even an endocervical curettage, in the case of a cone biopsy, this procedure is going to be performed under general anesthesia. And being a more involved procedure, it makes sense that we reserve this cone biopsy for CIN2 and CIN3, and therefore we are reserving our more involved procedures for further along in our algorithm in the evaluation of cervical dysplasia. So once we perform our endocervical curettage or ECC, and we see CIN2 or CIN3, we could perform the cone biopsy as we mentioned previously, or we can move on to a loop electrosurgical excision procedure or LEEP. In a LEEP procedure, we use a thin wire loop with an electrical current running through it in order to remove abnormal areas of cervix. We can appreciate this on the right-hand side of the presentation, where we can see this LEEP wire with an electrical current running through it, taking a sample from this cervix here. And this LEEP procedure has become more popular in recent years because unlike the cone biopsy, which is performed under general anesthesia, the LEEP procedure can be performed under local anesthesia. Although a cone biopsy is performed under general anesthesia and a LEEP procedure is performed under local anesthesia, there are several key similarities that underlie these two procedures. First of all, it should be noted that for both the cone biopsy and the LEEP procedure, that both of these are excisional procedures. They are indicated for high-grade lesions, meaning CIN2 or CIN3. Typically, these procedures are going to follow a positive ECC indicating CIN2 or CIN3, particularly in cases where there is inadequate visualization of the transformation zone, and therefore we need a diagnostic excisional procedure. And for both the cone biopsy and LEEP, these are both going to increase the risk of preterm labor as well as cervical stenosis. So we should always look for the presence of cone biopsy or LEEP in the history of patients when we are suspecting that it may be a question of preterm labor. For the sake of completeness, I would also like to mention briefly cryotherapy. In cryotherapy, as is evident in the name, we are using an extremely cold probe that is cooled down using liquid nitrogen. It should be noted that cryotherapy is not an excisional procedure, and it is really best reserved for low-grade lesions. Cryotherapy is very rarely going to be the answer on examinations. However, it is something that you may see clinically, for example, in the treatment of low-grade lesions such as CIN1. Bringing all these different procedures together that we use in the evaluation of cervical dysplasia, we have here a possible patient trajectory. Now let's assume that you have a patient who has an abnormal pap smear or abnormal HPV testing, and you then go on to perform a colposcopy. During that colposcopy, you may decide to perform some small biopsies during the procedure of suspicious areas, or you may go on to use an ECC. If the ECC demonstrates low-grade dysplasia, such as CIN1, then you may see clinically the use of cryotherapy or perhaps even laser therapy in order to get rid of these lesions. However, in the case of high-grade dysplasia, including CIN2 and CIN3, then you are really going to want to get a piece of tissue, in which case you can use either a cone biopsy under general anesthesia or a LEEP procedure under local anesthesia. However, for both the cone biopsy and LEEP procedure, it is important to keep in mind that because we are taking a piece of the cervix, these are both going to increase the risk of the development of preterm labor as well as cervical stenosis. Also, just to briefly recap on these procedures in terms of their safety during pregnancy, for colposcopy, this is completely safe during pregnancy. Additionally, performing small biopsies during colposcopy is considered to be safe during pregnancy. However, once we get to the endocervical curettage and beyond in terms of invasiveness, these are really to be avoided during pregnancy. ECCs should be avoided during pregnancy. as is the case for cone biopsies, as well as the LEEP procedure. And therefore, for patients with cervical dysplasia discovered during colposcopy during pregnancy, further evaluation of these lesions can generally be reserved for after delivery. One way that Pap smear results will show up both clinically as well as on examinations is via the Bethesda staging system. This system allows us to classify different patterns of cells that we get from the Pap smear at the vaginal cervical junction, and we then have standard pathways and guidelines which guide our management. Just to review some of the terminology that is involved here, we first of all have ASCUS, which refers to atypical squamous cells of undetermined significance. We then have LSIL, which refers to a low-grade squamous intraepithelial lesion. We have ASCH, which refers to atypical squamous cells, cannot exclude a high-grade lesion. One step beyond that is HSIL, which refers to a high-grade squamous intraepithelial lesion. And then we have AGUS, which refers to atypical glandular cells of undetermined significance. And you may recall from some of our previous videos, such as that on endometrial cancer, that in the case of AGUS, because this is a case of atypical glandular cells, this can sometimes represent what is actually a cancer of the endometrium rather than simply dysplasia of the cervix. What is great with the Bethesda staging system is that it ultimately gives us a framework into which we can determine the management based on the Pap smear result of a particular patient. Admittedly, however, we do have to get a bit into the weeds when it comes to the normal Pap smear, ASCUS, as well as LSIL, as these ultimately have an algorithm that we will need to consult and go through as we move through the rest of this video. However, if we have ASCH, in which we cannot rule out a high-grade squamous epithelial lesion, then we need to proceed with a colposcopy. Similarly, if we have HSIL, which refers to a high-grade intraepithelial squamous lesion, then we should proceed with a colposcopy. And as I hinted at on the previous slide, if we have a case of AGUS, which refers to atypical glandular cells of undetermined significance, then we should once again get a colposcopy. However, because these are atypical glandular cells, we cannot rule out endometrial cancer in these patients, and we should therefore also obtain an endometrial biopsy as well as an ECC. And this is really a great place to start in terms of learning the Bethesda staging system and how we manage patients with various grades of lesions, as once we reach the point where we cannot rule out a high-grade intraepithelial squamous lesion, or if we indeed have a high-grade intraepithelial squamous lesion, or if we have atypical glandular cells of undetermined significance, we are already in the territory in all three cases where we are definitely going to need a colposcopy in order to further evaluate the potential for dysplasia and cancer in these patients. Pictured on our screen, we now have an algorithm which allows us to determine the best course of management based on the patient's particular stage as determined by the Bethesda staging system. On the leftmost column, we have the Pap smear result, which again is going to be one of the various types from the Bethesda staging system. We can then split our patients into various age groups as well as status based on whether they are HPV negative or HPV positive. As I mentioned previously, determining the next step in management can get a bit nuanced for our patients who have a normal Pap smear result, for those who have ASCUS, as well as those who have LSIL. However, for our patients with more concerning Pap smear results, such as ASCH, HSIL, or atypical glandular cells of undetermined significance, as we have already discussed previously, these patients are all going to receive a colposcopy. Moving on to LSIL in terms of its management, as this is a low-grade intraepithelial squamous lesion, the majority of patients with LSIL are going to receive a colposcopy. This includes patients who are between the ages of 25 and 29, patients who are over the age of 30 who are HPV negative, as well as patients who are over the age of 30 who are HPV positive. However, for our younger patients, including those that are ages 21 to 24, considering that we start doing routine pap smears at age 21, for these patients with LSIL, we can simply repeat the pap smear in 1 year. As for many patients, this will ultimately resolve by the time that they reach age 25. However, if at that point it persists, then we simply proceed with a colposcopy in order to investigate this dysplasia further. Now that we've filled in our row for LSIL, we can now discuss our patients who have a normal pap smear result, as this is something that you will frequently encounter both clinically and on board exam questions. For patients who are ages 21 to 24, as well as patients who are ages 25 to 29, we can simply repeat the pap smear in 3 years. The same goes for our patients who are greater than the age of 30 but who are HPV negative. For these patients with a normal pap smear, we can either choose to repeat the pap smear in 3 years or perform a pap smear as well as HPV testing in 5 years. However, for our patients who are greater than the age of 30 and who are HPV positive, these patients are at a slightly higher risk of developing cervical dysplasia and cervical cancer. Therefore, for these patients with positive HPV testing, we should repeat our pap smear and HPV testing in 12 months. Finishing last but not least with ASCUS, which refers to atypical squamous cells of undetermined significance. For these patients, if they are between the ages of 21 and 24, or between the ages of 25 and 29, then we can simply perform HPV testing or repeat a pap smear in 1 year. As for many of these patients, this ASCUS reading will simply be a temporary one-time finding on their pap smear. However, for patients who are greater than age 30 and who are HPV negative, we should repeat a pap smear and HPV testing in 3 years. And for our patients who are greater than the age of 30 and who are HPV positive, we have a lower threshold in terms of performing further evaluation of their ASCUS finding, and therefore for this group of patients, we will proceed with a colposcopy. You can therefore hopefully appreciate from this algorithm overall that in the majority of cases we are going to proceed with a colposcopy, especially for the cases of lesions in our classification system, which tend to be higher grade or more concerning for dysplasia or cancer. In addition to the Bethesda classification system, we can also utilize the modern classification system, which splits the different types of dysplasia into 3 different types. These include cervical intraepithelial neoplasia, or CIN type 1, in which there is mild dysplasia involving just the lower 1/3 of the epithelium. In CIN2, we are going to have moderate dysplasia, which involves the lower 2/3 of the epithelium. And in CIN3, we have severe dysplasia, which essentially involves the full thickness of the epithelium. So if we were to draw out a schematic on the right-hand side of the presentation and split this epithelium into 3 different layers, if the dysplasia goes up to this layer here, then we can simply call this CIN1. If it goes up to the top of this second layer here, then we can call this CIN2. And if we have full thickness involvement of the epithelium up to this layer here, then we can call this CIN3, also known as severe dysplasia. It can sometimes be helpful to think of the modern classification system in terms of our Bethesda staging system terminology. As if we have a case of CIN1, then we can think of this as being the equivalent of LSIL, or a low-grade squamous intraepithelial lesion. If we have a case of CIN2, then this is essentially the equivalent of having a high-grade intraepithelial squamous lesion, or having atypical squamous cells in which we cannot rule out the presence of a high-grade intraepithelial squamous lesion. And if we have full thickness involvement of the epithelium or severe dysplasia, then this is equivalent definitively to a high-grade intraepithelial squamous lesion. Although the management of our different types of dysplasia using the Bethesda staging system were quite complex, when it comes to cervical intraepithelial neoplasia with the modern classification system, this can be much easier to understand and remember as a medical student. If we have a case of CIN1, this is essentially the equivalent of LSIL, We can simply repeat the patient's pap smear as well as HPV testing in 12 months, as this is generally considered to be a low-risk lesion, and in many cases will regress spontaneously. In the case of CIN2, we can perform a cone biopsy or a LEEP procedure, and similarly in the case of CIN3, we should also perform a cone biopsy or conization or a LEEP procedure. As in both CIN2 and CIN3, we are much more concerned in terms of these being more serious lesions. We have now discussed human papillomavirus in the context of HPV testing several times throughout these modules, as using HPV testing in conjunction with pap smear can increase our testing interval for cervical dysplasia from a 3-year window to a 5-year window in patients with normal pap smear results. We should therefore do a brief review of the various subtypes of HPV and what this virus can cause. In the case of HPV subtypes 6 and 11, this can ultimately cause genital or anal warts. Additionally, these subtypes of HPV 6 and 11 can cause laryngeal papillomatosis. And in the case of HPV subtypes 16, 18, 31, and 33, these can ultimately cause cervical cancer, as well as squamous cell cancers of other areas of the body, including the larynx. And therefore, for these subtypes of HPV, 16, 18, 31, and 33, we consider these subtypes to be high-risk subtypes of human papillomavirus. Another topic related to this that frequently shows up on the USMLE and shelf examinations is the HPV vaccine. We should ultimately give the HPV vaccine to all females between the ages of 9 and 26 years old. This is the case regardless of the patient's HPV status or history of HPV-mediated disease. Additionally, we should give the HPV vaccine to all of our male patients who are between the ages of 9 and 21 years old. It is also important and high yield to recognize that this HPV vaccine protects against HPV subtypes 6 and 11, as well as high-risk subtypes 16 and 18. However, unfortunately, this HPV vaccine does not protect against the other high-risk subtypes, which include 31 and 33. And therefore, although this HPV vaccine can be helpful in ultimately preventing progression to cervical dysplasia and cervical cancer, patients who receive the HPV vaccine still need to be screened for the development of dysplasia and cancer, especially given that these subtypes are not protected by this vaccine. When it comes to the development of cervical cancer, there are several important risk factors that we'll need to be aware of. These include, of course, our high-risk HPV subtypes, including 16, 18, 31, and 32. Smoking is also a very significant risk factor, and this is something that you will frequently see in board exam vignettes when we are describing the patient's comorbidities and social history. Additionally, immunodeficiency is a significant risk factor for the development of cervical cancer. Additional risk factors include having multiple sexual partners, having sexual intercourse at a young age, alcohol intake, being of low socioeconomic status, as well as having in utero exposure to diethylstilbestrol, also known as DES. As we finish off this module, I would like to just briefly review how cervical cancer typically presents on board exams. There are really two classic categories of how this cervical cancer is going to present in our patients. The first of these is postcoital bleeding, which refers to bleeding from the cervix following sexual intercourse. And the second classic presentation of cervical cancer is with metastasis in late-stage disease. Some classic patterns of spread for the cervical cancer include spreading to the bladder as well as the rectum, which can result in urinary or fecal incontinence. The cancer can metastasize to the ureter, resulting in a blocked ureter and hydronephrosis. Additionally, cervical cancer can also spread to the lungs, and these patients can present with hemoptysis and shortness of breath. Therefore, if we have a board vignette in which a patient presents with postcoital bleeding, or who has any of these different presentations of potential metastasis, particularly in a patient with some of the risk factors for cervical cancer, including having HPV, as well as a smoking history or a history of immunodeficiency, then in these patients we should have a very high index of suspicion that this patient may indeed have a case of cervical cancer. And because cervical cancer tends to present in its metastatic and late stage in terms of its progression, this is why we're so aggressive in terms of screening our patients for cervical dysplasia with the hopes that we can ultimately prevent our patients from developing cancer of the cervix. And therefore, as you go through these different algorithms for interpreting pap smears, looking through the Bethesda system, as well as the modern classification system, I urge you to think about these patients in terms of their late-stage presentations and how we can best prevent them from ultimately progressing to this point when their prognosis is simply not very good. This is BoardsMD, and this is Cervical Dysplasia and Cancer.